Hi, this is Stacy State with Advantum Health. I want to welcome everyone to today's webinar regarding credentialing and provider enrollment. Thank you all very much for taking time out of your day. The webinar will probably last between anywhere from 30 minutes to about 45 minutes, and we'll leave some time at the end for questions. There is a questions area on the GoToWebinar. So throughout the presentation, if you have any questions, I will be looking at and monitoring those. So if there's a good stop during the presentation, I will stop us and ask the question then. Otherwise, we'll save all questions to the end. So without further ado, I want to go ahead and introduce our speaker, and then I will turn it over to Sarah. So Sarah Wilson has been in healthcare for several decades. She started as a practice manager and went on to actually oversee the physician practice of a large health system. When she was at that health system is when she actually discovered and found many of the weaknesses in both the contract payer negotiation process as well as the provider enrollment process. So throughout her tenure there, she got more involved with both the credentialing and verification process and developed many operational and financial best practices within the health system. Within that first year of her developing those processes, the organization that she was with actually had the best year financially due to some of the contractual enhancements and timely enrollment. So without further ado, I want to turn it over to Sarah. She's going to walk through some of the common mistakes that people make, as well as the impacts it could have to your organization, and then also some of the costs that a lot of people experience and the headaches throughout the provider enrollment and the credentialing verification process. So thank you, Sarah, and I will turn over to you.
Thank you, Stacy.
You should have controls.
All righty. Can you see my screen now?
We can.
All right, perfect. Well, I want to thank you all for coming out today. It's good to have you all here. Just want to speak to you about provider enrollment and credentialing verification. We'll start off with just kind of a brief description of what provider enrollment is. There is really broken down into two components. You have credentialing and re-credentialing. Credentialing is the process of procuring, verifying, and analyzing the eligibility and qualifications of the provider rendering healthcare services. The act, and it is the act of contracting and enrolling a provider in our group with payers in order to submit healthcare claims for payment at a contracted rate. The maintenance of re-credentialing is the maintenance of an existing enrollment that serves as a required renewal with the payer, and these renewal periods vary by plan. Why is enrollment important? Well, whether you're adding a new provider, opening a new clinic, or adding additional services, notifying a payer of these changes, and contracting appropriately gives you the ability to bill for services and be compensated at a contractual rate. Without proper and timely contracting in place, you risk the loss of revenue. We recently had a client that came to us, and upon initial evaluation, it was discovered that they didn't have their CLIA certificate on file with Medicare and Medicaid. So all of their tests that they were performing, they were not getting reimbursed for. So just making sure that that you are covered contractually can make a big deal to a practice. Typical cost of enrollment. An inefficient enrollment and verification process can cost you both time and money. The below analysis is based on the following assumptions. The average time commitment of providers is 15 hours. the average number of payers per provider is about 15 is what we've seen. And then the average time commitment for a provider is about 15 hours. The average time commitment for staff ends up being about 90 hours. And then the average, when you factor in the staff cost at about $20 per hour and the salary of a provider, roughly $130 per hour, you can see how these costs can really add up pretty quickly. So the cost of enrollments, many studies show that a physician practice with 10 to 20 doctors can easily spend $7,000 per year when you're adding providers or maintaining existing credentials. So these costs can easily add up, not just in administrative overhead, but it consumes the time of your staff and the physicians there. So, which could definitely be better spent by seeing patients. So, we'll get into the 7 key mistakes. So, mistake number 1, I just call this failure to launch. This is simply just you've decided to add a provider and you have to get all your ducks in a row. You have to have some very basic information just to get started. You need a copy of the provider social security card, the NPI username and password. This allows you to access not only their NPI registry site, but also it gets to the Medicare PACO system. The CAQH username and password, which we'll talk more about in a second, an updated CV, a current medical license in the state of practice, a DEA, again, that's specific to the state of practice, diplomas, having a copy of the medical school residency and all of those diplomas. A lot of times, too, if you have a provider who's moving, those things are a lot easier to get prior to their move than afterwards. So board certification is, a current copy of the board certification with dates and certificate of insurance that is specific to your practice location. All of the additional sites of service that the provider will be providing services, their hospital affiliations or admitting arrangements, and then, of course, the provider contact information. But it's just having all of these items in place prior to being able to start the enrollment process. CAQH, I'm sure most of you are familiar with that, which is the Council for Affordable Quality Healthcare. CAQH, kind of the basics. It's not required for hospital-based providers. The provider's account belongs to them. It's similar to MPI, where they'll only have one CAQH enrollment, and it will be maintained throughout the life of the provider's career. The insurance companies pay to access the site, but it is free to the provider. So insurance companies go to CAQH first before they come to the practice. So you do try to keep it updated with all information. So when you're up for renewal for your state license or your DEA, board certification, certificate of insurance, all those important documents, you want to, as soon as you receive those things, you want to keep that CAQH up to date and current. So instead of the plan having to reach out directly to the practice, they will find that information located on CAQH. So it also contains a 10-year work history with that you have to explain any gaps of employment that were greater than 3 months. This work history really begins from the date that they completed their medical training. So if you have a brand new provider, of course, they won't have any work history. The also includes a disclosure statement that where you have a 10-year explanation of any malpractice suit, and that's really anything within 10 years that was filed or settled or paid that's out there. So you have to, anything that's occurred within the last 10 years, you have to have that listed on that site. CAQH requires an initial attestation, and then reattestation is required every 120 days. Applications to commercial payers cannot be submitted until the CAQH is complete and or updated. Number 2, it's about time. This is probably the most critical one. So government payers, Medicare and Medicaid, these applications are generally submitted first. These enrollments are state specific. So if the provider is not enrolled with Medicare or Medicaid with the new practice location state, this is considered a new enrollment. So if you have a provider in Texas that is moving to Kansas and he's enrolled in Medicare in Texas, you'd have to re-enroll him in your Medicare just like he's a brand new provider. It's a different jurisdiction. And then for commercial payers, once enrolled, CAQH is updated with the current practice information. Commercial payer enrollment can begin. Now, the best practice is to contract on a group level, which is what I always strive to do, so you can link providers to your existing group contract. And but some plans do require that contracting be completed on a provider level. Payers require all information to be submitted, verified, and approved and loaded in their system before you can submit claims to be at that in-network rate. And those enrollment times vary by payer. And they can be completed in as few as 30 days, or I've seen them take as long as a year. So the biggest key is submission of enrollments prior to a provider start date is critical to success. And day one, doctor on board and paperwork to payer, 30 days, still waiting, no patient seen or claims released. And day 60, one payer done, few patients seen, and then it can take really, most plans are about 120 days. But you can really, though, see the most important rule here is about time, is about getting the information out to the payer before that they start seeing patients within the practice. Oh, provider, where art thou? So there are several plans that require original signatures on applications, such as Medicare. A provider that is joining your practice that's located in the same, they may be in the same town, but it can just be a challenge to get them to stop by the practice to sign those applications. But a provider who's located in a different state or across the country, it can be a real slowdown there getting those signed forms back. So always try to allow time to get those required signatures well in advance of the provider start date. And if you know that they're coming into town or there's a specific date that they're stopping by the office, you just want to be sure that you get that, have all those signature pages there for that provider to be able to sign and complete any applications. What's in a name? Whatever name is listed on the Social Security card is the provider's legal name. Similar to the business goes off the IRS letter. CMS compares the provider's information to that on file at the Social Security Administration. So you always want to make sure that the name listed on all official documents should match the name listed on the provider's Social Security card. This is including the state license, DEA, NPI, name on CAQH, enrollments with payers, and the name that you are submitting claims under. Variations of name can cause delays. So probably the most common thing that I've seen is the example number 1 down there, where a provider has, for lack of better terms, a nickname that they go by. So like Dr. Jonathan Day, Dr. Johnny Day. I mean, his buddies, or he may go by Johnny personally, but professionally his name is Dr. Jonathan Day, if that's what's listed on his Social Security card. Having variations of your practice name too, like Orthopedics of KY versus Orthopedics of Kentucky, the pain specialist versus the pain consultants. I mean, again, all of these you want to be sure that you're using the legal business name as well as the provider's name as it's written on their Social Security card. Variety is not the spice of life. Each payer has specific form, and each payer has different requirements with supporting documentations and different formats that these applications and enrollments can be submitted. Electronically, some can be submitted by fax, others by email, others by mail, and sometimes it does feel like horse and buggy, but okay, maybe not that one. So getting the information to the payer in a format they accept in its entirety is key to starting the enrollment clock. And so that that submission date is very important because each plan has a number of days that they allow for an application to be processed. They have a standard amount of time, whether it be 60 days, 90 days, 120 days. But you'll check with the plan and they'll say, oh, now we have 60 days to process this application. So if it was received on April 1st, you can keep checking back to confirm that everything's moving along appropriately, but you can't start really forcing or asking questions about the enrollment until you've reached the end of that enrollment period. So that submission date is really, really important. So not only is the original submission a challenge, but you also have to maintain your documents, monitor CAQH, recredential, and update expirables. Oh, and see patients and manage the practice. So again, when you submit these enrollments, you'll just have natural things. Your DEA may expire, you may have license. So maintaining all of that throughout your enrollment period is critical and key. And just as in real estate, it's location, location, location. With enrollments, the biggest thing it is follow up, follow up, follow up. So follow-up begins upon submission. So upon initial submission, there are certain plans that will issue a tracking number. And so you know that you have a way to follow up with the payer. There's a specific identifier that's been assigned to that application. But for other plans, you need to follow up within about 2 weeks to ensure the application has been received. There are some payers that require a little bit longer to get the application imaged into their server and then uploaded into their system. So then you follow up at regular intervals until the enrollment is complete. And so follow-up takes time. It takes a lot of time. So it really is a labor-intensive process. And then once a provider is enrolled, once we get notification, we want to follow up one more time and make sure that the information that's loaded into their system is accurate, that the practice demographics are accurate, the practicing specialty is accurate, and make sure that the file is loaded, and you want to confirm that everything is complete. They're linked to the group, tied to the tax ID. Again, this is on both ends, on the enrollment side as well as on the entry side by the plan. It's a very manual process, and mistakes do occur. So you'd much rather find out initially from the setup than from having denied claims. And then as you move through the process, a provider may decide to change hospital privileges, or you go through practice name changes, or you add a new service location or provide a new service, or allow an insurance to lapse. You must update. And the biggest thing when you're working with payers is this is really a relationship game. When relationships matter, when you're working with payers on a regular basis, you develop a rapport with the payer contacts, and these relationships can make a substantial difference in really problem solving, whether it be through new enrollments or whether you're working denials. Those relationships are key. And then when in doubt, reach out. We've had an experience where if you ever experience a roadblock with a payer, we definitely want to keep the client in the loop. I recently had experience with a practice that we were having a real slowdown with the health plan with getting their providers' information, getting their contract loaded in the system and their providers' information input. And it just so happened that the practice manager, she went to high school with the health plan CEO, and she messaged him via Facebook, but she got their group's information. It was done within 24 hours. So that was, you never know who you know. So you reach out I'll let you know, because we'll use any advantage we can for sure. And lastly, this is a job that never ends. Once you're enrolled, your providers will require recredentialing with each plan, and this time frame varies by payer. So you also want to watch your denials, because payers make system upgrades that can generate denials. And the very first step when you're seeing a large volume of denials is to verify verify enrollment, make sure everything's still accurate and current in their system, that there wasn't some glitch, that the payer got kicked out. We recently had a health plan here in Kentucky that we were pretty much seeing the same denial. They had two different provider types, whether any groups with physicians and nurse practitioners. They were paying one side, but the other was the claims were getting denied because it was stating the MPI was expired, which MPIs don't expire. So, but when it turned out to be a statewide issue, and it took them about 4 months to get that fixed before they instituted a global claims project to get that corrected. So again, it's staying on top of those denials and managing them accurately. So again, CAQH must also be kept up to date with quarterly attestations and maintenance of expirables, and then maintaining enrollments in credentials, having a technology platform to store documents, utilize software to monitor status and provider alerts for expirables, develop a process for updates, developing a relationship with key payers, maintain customized forms for easy updates, and work with the CBO, especially for larger practices where you can do some delegated contracting. That is absolutely fantastic. And then check in with the billing department to ensure payments are processed accurately. So the financial impacts. So again, this is a real easy piece here where you see in this scenario, Advantum Orthopedic Group has 10 physicians that all need to be credentialed with local and government commercial payers. If they have 15 payers each, and the annual physician salary is $477,000, and the average day to complete enrollment is 90 days. If each orthopedic surgeon has to wait 90 days for approved credentialing, the delay in AR or potential loss could be as much as $1 million, so, or more. So it is a substantial amount of loss. You try to mitigate that at every point possible. So enrolling early is the key. So kind of in summary too, the major concerns that practices lose sleep over include getting delayed in signed contracts on the provider side, or signed enrollments on delayed signed contracts on the group side, and enrollments on the provider side. Getting the required information in a timely manner, whether it's that certificate of insurance, which is below, but that is, the certificate of insurance is a real hold up when no one wants to go ahead and pay for certificate of insurance when the provider's not yet there. But again, you have to have a certificate of insurance that is applicable to your practice location. And then the DEA enrollments, they're state specific. So again, if you have a provider who's in the same state as your practice, that's not an issue. But if they're coming from one state to another, you do have to update that DEA, change the state of practice, unless they're having multiple state practice locations, in which you have to have multiple DEAs. Unrealistic time frame, it's just building that into your plan where you are adjusting accordingly, whether it's, we can certainly hold claims, or you can hold claims and release them as you get those approvals, having knowledge of your plan and what plans will backdate, or what dates will use their date that they credential as their effective date of their enrollment. So, and setting your time frame accordingly. Then lack of response from practice or a provider when you just can't get the information that you need back from anyone. And then delays in licensure and certifications, especially for new providers. And then lastly is the name match, for everything matching on the group side as well as the provider side. On the group, it's to the IRS letter. And then on the provider side, it's the Social Security card. The Advantum Health Advantage. So Advantum Health is a revenue cycle management company, and provider enrollment is just key to payment. The enrollment team works closely with our billing team to ensure the group and provider is set up correctly in the system from the start. Then we work together to hold claims until the enrollment is completed, and then release each payer as that enrollment finalizes. Communication is king, sharing the expected time frame for enrollments, keeping the practice abreast of progress, or informing them of any delays or obstacles. And then once a provider is enrolled, it really is critical to watch those denials and see where your issues lie, and then confirm that that they are related to your enrollment, and that they are. If there's any way to argue those denials contractually speaking, we'll be glad to do that for you as well. But wait, there's more. So Advantum Health recently acquired MedAdvantage, which is the largest independent provider data center performing credentials verification organization, CVO, services and provider enrollment services as well. So the Advantum Health and MedAdvantage, Advantage is they process over 1.8 million applications. They maintain a database of over 1 million providers, stores over 3,000 unique forms and documents, provides database and application management, completes primary source verification, NCQA, URAC, JC, AAA, AHC, establishes direct access to the National Practitioner Data Bank, the FSMB, the ECFMG, and other national databases. Offers a comprehensive revenue cycle service that incentivizes a faster, more efficient credentialing process. Final thoughts. So contracting with payers is really an ever-changing landscape. Even well-established practices add new payers, especially in the exchange market environment that we're all living through now. Contracts with payers are legal contracts that set forth the rules of how the provider does business with the company, and these vary by payer and include rate of reimbursement, your time that you're allowed to submit claims, their timely filing rules, and the contracts can be negotiated at specified renewal times or any time, but it works better within your specified renewal time. There's only one sure thing in life, is that problems will and do occur. So what matters is how quickly they are identified. And always remember is all problems have a solution. Some are just easier than others to solve, but they all have a solution, and we can certainly work together to fix any issue that's out there. So I think I've spoken pretty quickly here. I apologize. But if you have any questions, I'm here, and I'm glad to answer anything that you have.
Thank you, Sarah. I will keep the line open for questions. And I appreciate everyone's attendance today, and hope that you all learned quite a bit about the verification process and provider enrollment. The webinar will be distributed after, once it's available to all of the registrations and attendance today. And we appreciate your time. And again, I will leave it open for questions. Just submit them through the question box if any came to mind. Okay, there is one question that came in regarding medical students, residents, and fellows, and how to go about credentialing them, whether they need credentialing. So Sarah, I'll turn that over to you.
So medical students can get a state license after, depending on your state, but most are after a year after they complete their first year of medical school or so. So as soon as the provider gets a state license, they can then apply. With, in particular, the largest area of concern would be for Medicaid and for Medicare. So you would want the ability to add them either as the easiest way to add a medical student would be, or a resident would be, to add them for as an ordering and referring provider if they're not going to be billing for services. If they're moonlighting, then you have to have an approval letter from their program that their residency program that they're in good standing and that they have the permission of the residency program to moonlight. From there, Medicaid's the same way. You'll have to go in and just complete a provider enrollment. So that allows the provider to have the ability to write orders and prescriptions for those patients. Many commercial payers, you'll get a few that will enroll a resident, but until they've completed their training, there are a lot of plans that simply will not enroll them. So it's one of those that if you have to, I understand, been there, done that. So you get what you get, but at the other side is that there will be certain plans that completion of residency training is a condition for participation. So did I answer all that, Stacey, or was there another part to that question?
No, I think that answers that question. There's another question around privileging and what additional, if any, information is required for specialty privileges and how that's, how to treat that differently than the primary privileges.
So, the biggest thing that with privileging, and I'm assuming we're speaking of hospital privileging here for a specialist, is there will be a stock list that each facility will provide of that they will have the option to services that they actually provide. And so some procedures and all that you would perform you have to show clinical competence or some educational training that it was concluded. But that is the delegation or the privileging aspect there is really about, signing up for what services, whether it be, there is moderate sedation. That's something that generally you have to have completed training at that facility to show your competence and things like that. So, but then if you're orthopedic surgeon, there may be a variety of different orthopedic procedures that you want to say, I need this privilege, but I don't need this one, that the provider themselves has to answer for.
Thank you, Sarah. Okay.
You're welcome.
There are no more questions at this time. All right. Well, as I mentioned, the webinar will be sent out once it's available to everyone that registered and attended today. So we appreciate your time. If you all have any additional questions, please feel free to reach out to Sarah or myself. And we appreciate your all's time today. Thank you.
Thank you.